is Katie. I'm one of the PGY3s at University of South Florida. And today I'm going to be discussing with you a condition known as hypertension associated with, or hypertension and brachydactyly syndrome. So I'll start by pointing out that as we know, hypertension is an extremely common condition in adults, but in children, genetic hypertensive syndromes are much less common and as a result are likely under-recognized. So as a result, this can lead to delayed treatment and obviously some morbidity and mortality. So this case is a 7-year-old patient who was seen in the outpatient primary care clinic. He was noted to have elevated blood pressures associated with headaches. And due to lack of known risk factors or family history, he underwent an extensive workup for secondary causes of the hypertension. He had labs including BMP, thyroid enzymes, serum renin, 24-hour urine catecholamines, and a urinalysis, and they were all normal. He also had a renal ultrasound with Doppler, as well as a 2D echo that demonstrated unremarkable findings. He was set up with an ambulatory blood pressure monitor to confirm the diagnosis in the outpatient setting, which demonstrated max blood pressures as high as 157 over 107. So he was initially treated with conservative measures, low salt diet, but his hypertension persisted. And as he began to grow, he was noted to develop short stature, which you can see in figure 1 on his growth curve. He dropped from, I believe, about the 16th percentile to about the 3rd percentile in just a few years. And this was just his height. His weight continued to follow his growth curve, so height was disproportionately affected. He was also noted as he grew to have short, thick fingers and toes, which you can see in figure 3. These factors together raised concern for a potential hypertension with brachydactyly. However, he had no known family history of this condition at the time. So it was discussed further, and it was determined that he actually did have his father and his half-sister who had similar phenotypic features. They both had thick, short digits, as well as hypertension that had been present since their teenage years, but they hadn't received any sort of diagnosis. So because of all this, he was recommended to get x-rays of the hands and feet, but the family did decline. Regardless, he was given a presumptive diagnosis of hypertension and brachydactyly syndrome based on the fact that he had this hypertension persistent from a young age, the short stature, and the presumed brachydactyly. So I'll talk more about the condition really quick. It's a rare autosomal dominant disorder characterized by early onset severe hypertension, short stature, and brachydactyly manifested by shortening of both the phalanges and the metacarpals. Its extremely rare prevalence is estimated at about less than 1 in 1 million. It's a salt-independent condition, so doesn't respond to changes in salt in the diet, and if left untreated, can lead to recurrent strokes prior to the age of 50. So obviously that can be pretty detrimental if left unrecognized. So this case demonstrates the utility of phenotypic features when it comes to recognizing genetic hypertension syndromes. It can aid in early recognition and diagnosis, as well as recognition in family members and counseling for the future. So in our case, obviously this condition was not known to be present in the family until these phenotypic features were seen in the patient. And as a result, he was able to not only receive a diagnosis for himself, but as well as his entire family. So again, even if the phenotypic features are mild, anyone with any of these features should undergo ambulatory blood pressure monitoring and be initiated on early treatment to reduce morbidity and mortality, because the untreated clinical course of this disease can be very detrimental and lead to like recurrent strokes, like I mentioned, and other unwanted outcomes. So I'd be happy to answer any questions.
Alrighty, thank you. I actually have a question.
Mm.
So you say that he was started on lisinopril initially, and then as he aged, it persisted. How was his management changed? And was he able to get down to a normal BP?
So the hypertension actually persisted despite a low salt diet, but once he was started on lisinopril, he responded appropriately to the medication. So he was able to get down to normal blood pressure is less than 120/80 with treatment. Awesome. So I forgot to mention something to you all because it's not actually written on the poster. But anyway, I mentioned that this syndrome is an autosomal dominant rare cause of hypertension as well as some other phenotypic features. But what I didn't mention is kind of what's been found genetically when gene analysis has been done. And so people with this syndrome who have had genetic analysis done have demonstrated a missense mutation in the PDE3A gene, which is expressed in platelet, heart, and vascular smooth muscle. And it encodes phosphodiesterase 3A, which hydrolyzes cyclic GMP and cyclic AMP. So we all know cyclic GMP is responsible for smooth muscle relaxation, so makes sense here. And the mutation is most often a gain of function variant, which again makes sense. So I just wanted to add that because, you know, when it comes to genetic conditions, a lot genetic testing is expensive and a lot of time it's not done, and so that just kind of lends more importance to what I was saying before about the importance of looking at these phenotypic features and using those as clues to look into the possibility of this diagnosis and using that as a presumptive kind of diagnostic tool. So that's all I wanted to add.